Ladies and gentlemen, thank you for your patience in holding. We now have our speakers in conference. Please be aware that each of your lines is in a listen-only mode. At the conclusion of our speakers' presentations, we will open the floor for questions. Instructions will be given at that time on the procedure to follow if you would like to ask a question. It is now my pleasure to turn this conference over to Chris Hund. You may begin.
Hi, thanks, Chantel. This is Chris Hund with the National Implementation of TeamSTEPPS program. Thank you all for coming in and joining us today for our second webinar of the year. This one is TeamSTEPPS for Patients and Patient Engagement. So happy mid-March, and I hope that it is spring wherever you are. Just a few acknowledgments as we start. This whole project is sponsored by the Agency for Healthcare Research and Quality, which is a part of the Department of Health and Human Services. And so I'd like to thank them, and especially Dr. Jim Battles, as well as all of the support and knowledge and content that comes from Heidi King and the Department of Defense, who have always been integral in the TeamSTEPPS program. The AHRQ National Implementation is run by AHRQ, which is part of the American Hospital Association. And we'd also like to thank our partners at Impact International, who are very important partners of ours and help us put together a lot of our work, as well as the regional training centers around the country. Duke University, North Shore Long Island Jewish Health System, Tulane University, University of Minnesota, and the University of Washington. So just a couple quick words before we get started here about the program. So we do run the TeamSTEPPS Master Training courses at the 5 centers I just mentioned, and they are two-day training courses, train the trainer approach, and they are what we think would help you best prepare to go back to your institution and train others in TeamSTEPPS. But we really think that this is only the first step in a very, very long implementation journey. And one of the ways are things like this webinar that we produce to help you in that implementation journey. We have something called the TeamSTEPPS portal that we always like to mention on every webinar, and that is at teamsteppsportal.org. And you can register there and create an account. And this user support includes webinars. We have some tools and resources for use up there. There's going to be a lot more coming soon. We're also putting out feelers for implementation stories. So if any of you have a good story out there in the community, there's a little button on this website that you could press, fill out a quick form on a SurveyMonkey, send it to us, and we'll be contacting you to help write up your story so you could share it with the community. There are also discussion forums and an ability to sign up for matchmaking, which would help us connect you with an expert to come out to your hospital in case the regional training center model doesn't work for you. I'd also like to take a quick moment to talk about the 7th Annual National Conference. It's going to be in Dallas, Texas, June 12th and 13th. And this conference, I think, is going to be very exciting this year. We've got a lot of great people turned in abstracts. We're really expanding the knowledge base, I think, this year, getting into some new innovations, some new ways that technology can be a part of TeamSTEPPS, and I hope that it's a very enjoyable experience for everyone. Spots are going fast. There's actually, I would say, over 2/3 of the spots are already filled, and it's only been open for about a month. So head on over to the portal and click on National Conference if this is something you're interested in going to. And as always, we have this helpline and that help email address available for anybody who has any questions about TeamSTEPPS or about master training in general. So this is something that you can call us up and we could answer questions for you, and we try to be very timely about this. So this number and this email is posted also on the National Implementation Portal I talked about, and so that's a good place for you to go if you have any questions. Some quick rules of engagement for today before we get started. If you look in the left-hand corner of your desktop right now, you see a discussion area. That's a place where we encourage you to ask questions throughout the course of the day, and we will answer these as they come up. And some of them that are really, really good points or really good content we'll save until the end and then ask them of the presenters so that they can answer them and everybody can hear the answer. We also will have an actual Q&A session at the end as well where people can, physically ask their questions, and the instructions will be given about that when the lines open up at the end of the presentation. So I would like to now introduce today's webinar presenters, two people that I've heard speak before and that I think you'll enjoy and that do an absolutely great job at this. The first is Tiffany Christensen, and she is a Duke University hospital patient advocate, and she has a very unique perspective, and if you haven't had a chance to hear her before, I think you're going to really enjoy her story, and it is a very good experience to hear her speak. Also on the line is Dr. Karen Frush, and Dr. Frush leads up our TeamSTEPPS Regional Training Center at Duke University, but she is much, much more than one of the leading minds in TeamSTEPPS. She also holds many positions, as you can see, at Duke, and is just a really wonderful person and a great asset to all the work that we do. So I'd like to turn it over to Tiffany now to begin the presentation proper. Tiffany?
Good morning, or good afternoon, rather. Thank you all for signing in. We're going to be talking today about several things. We're going to be looking at TeamSTEPPS, kind of breaking down what TeamSTEPPS is and how we might think about implementing it to engage patients and families to decrease medical error and increase patient satisfaction. And the next slide, please. We at Duke don't have the rights to change the slides here, so we're going to have to ask for it to be forwarded for us. So today we're going to be discussing safety from a patient's perspective, and today you're going to hear my perspective of that. We're going to be describing how to create a good, safe place for patients and families so that they can strengthen the patient-provider partnership using TeamSTEPPS tools. So we'll get into that towards the end of the presentation. Next, please. So one of the things that we've learned over time is that no matter what you are trying to accomplish at your health center, whether it is patient-family-centered care initiatives, whether it's safety initiatives. So one thing that we know now is the greatest motivator for change is story. And so the reason why we've decided to start with my story is simply that, to kind of start at the place of the beginning, if that makes sense, to start with what it is that brings us to the table in the first place. So without further ado, next. So I was diagnosed when I was 6 months old with what I consider to be the gift of cystic fibrosis. I've always had a sense that this disease was not a mistake, but in fact it was something that was given to me on purpose. It was something I was meant to learn from and to grow from. Next, please. So I know you must be very impressed by my outfit there. That's me at the age of 12 when I had my first hospital stay. I was inpatient at Duke Hospital for 3 weeks of intravenous antibiotics. And it was at this time when I was wearing that beautiful sweater dress and had my hair very hairsprayed like we like to do in the 80s that I started to understand what it was like to be a patient in this very complicated healthcare maze of ours. What I learned very quickly is that there is a fine line when you're trying to be an advocate for yourself or when you're trying to advocate for your family. There's a very fine line between being an offensive patient advocate and an effective patient advocate. And so this is something that I continue to strive for today, is working to find that line and also working to find strategies that enable us to find that line in a more concrete way. Next, please. So that was just the beginning, of course, countless nights of being in the hospital, pokes and prods, procedures, all that fun stuff. So we'll fast forward to the next slide. So by the time I was 21, I was pretty much sick all of the time. I had to drop out of college, which was a devastating thing that I had to do. But my illness had progressed to a place where I really wasn't able to keep up with my classmates anymore. And it was at that point that the doctors decided I needed to be on a list for a double lung transplant. So they listed me in, I believe it was the year 1997, I believe. Fast forward. Next slide. So I waited for 4 years for my call, and by the time it came around, I was about 95 pounds, and my lung function was roughly 25% of capacity. For those of you who are familiar with lung transplant medicine, you know that these numbers would not get me transplanted today. I would be considered too healthy. But this was back on a different system of lung allocation. So my number was up, and it was time for me to go to the hospital and get my new lungs. Next slide. But unfortunately, things did not go the way that we had all planned that day. I went into the holding area, and I said goodbye to my family. I kissed them, and I got wheeled back to the operating room. They put me on the table. They put the mask over my face, and I counted backwards from 10. I think I got to 9. And then the next thing I knew, I was awake. But I had been well trained by my team. So I knew that I was supposed to be in ICU, and I knew that I was supposed to be intubated. But in this case, I wasn't. I was actually back out in holding, and I had an oxygen mask over my face. I was tied down, and I was having a really hard time breathing. So I knew something had gone wrong. I began to flail around. Quickly, a nurse came to my bedside. She reassured me. She told me she was going to get my surgeon. He quickly came and began to tell me what had happened. Now, please forgive me, I don't have a clinical background, so I will explain this to you as he explained it to me in layman's terms. But basically what happened that day was that they had taken me into the OR. They had begun the surgery by making the first clamshell incision on the left side. They had lifted my ribs up, and they were about to take out the first lung when they got a call from the donor end of things that the cardiac surgeon had cut the tubing too short on the lungs, and they were not usable. So at that point, they had to make a very difficult decision. They ultimately chose to close me back up and hope that I would be okay. I feel fortunate that I had the lung function and the health at that time to be able to withstand that operation and be able to recover. What I know now is that transplant protocols have changed at my hospital since that incident, and they no longer put a patient or a prospective recipient under anesthesia unless the organs have been procured. So that was a positive outcome from a not-so-positive experience. But what I remember from that day as the patient really was the apology from my surgeon. My surgeon came to my bedside, and he did not try to deflect. He did not try to pretend like this was no big deal. He really just stood there and apologized from the bottom of his heart. And it was that apology that really enabled my family and I to be able to move forward from that place with our trust still intact with the team. Next slide. So that's me in ICU on April 4th, 2000. I waited one more year after that call for my real transplant. And I think the most important thing about this slide is that while it looks like I'm not aware, while it looks like I'm completely out of this body, I am, in fact, very much aware of what's going on around me and to me. I remember that moment very clearly. I remember my sister took a picture of me, and then her husband turned to her and said, "I cannot believe you just took a picture of her. That is so inappropriate." And then she turned to him and said, "Well, she told me to, Paul, so what am I supposed to do?" And I'm thinking, that's right, Jill. You tell him. We had this conversation. So even though I didn't flinch, even though I didn't react to the flash going off, I was very much aware of what was going on around me. I was very aware of people speaking over me. I was very aware of people talking about me. And I always wanted to know what was going on. So I think the most important lesson that I take away from this photograph and from my experience is the fact that no matter what state of being I am, as a patient, I want to be a partner in my care. And even in this state of being, when I could not communicate, I still wanted to partner. And the only way that I was able to partner in this day, in this ICU setting, was to listen. And so I very much appreciated the people that would communicate with me, that would touch me, that would talk directly to me, and knew that there was a lot more going on in the inside than you could see on the outside. Next, please. So I did really well for 2 years. Unfortunately, 2 years and 2 months after my double lung transplant, my lung function started to drop, and I was diagnosed with chronic rejection. Next, please. So that was a tough day. My physician said to me that I had chronic rejection, and everything after that point was sort of like the Peanuts character's teacher, where his mouth was moving and there was sound coming out, but it just sort of sounded like bop, 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 bop. I had absolutely no idea what he was talking about. And when I went home, I really had no information about my diagnosis, my prognosis, or my treatment options because it simply didn't stick in my brain. And so now I'm a big advocate for follow-up appointments after traumatic news has been given because none of us, patient, family, or professional, have any way of knowing what information we were able to retain and what information just went over our heads. Next slide, please. So I got sick pretty quickly. That's actually not true, though. Within 2 years, my lung function had dropped to 10% of capacity. I was 73 pounds, and at that point, the doctors estimated I had somewhere around 6 more months to live. Next. So I was driving down the highway one day, and it dawned on me that I had 1 double lung transplant. Why couldn't I have 2 double lung transplants? That seemed like an easy fix. So I called my team, and I told them my great idea, and they said no. They said second transplants were not as successful, and they did not want me to pursue that option. They wanted me to prepare to die, and that's what I did. So I can tell you that after all of those stages of grief that we talk about, those cycles, I did find myself in a deep place of acceptance and joy. Next. And then along comes my new lung transplant coordinator. She was blonde, perky, she just got the job, she had a whole lot of energy, and she called me up and she said that she wanted to help me get on the list again. Next slide. And as you might imagine, given the fact that I'm speaking to you today, I was listed 4 months after I was listed. I got the call, and despite everybody's concerns, the second transplant for me was much easier than the first. Next. So there's a funny thing that happens when you have 2 major medical interventions. People like to ask me a lot if I've jumped out of an airplane yet, because in our culture, when we want to prove that we're grateful for our lives, we think we should put our life in jeopardy. And while that doesn't make sense to me, I'm not going to jump out of any airplanes. I did jump off of a sand dune in Kitty Hawk, North Carolina, which I hope will then prove that I am grateful for this opportunity. Next slide, please. But more importantly, I have gone into the kennel and I've adopted 2 beautiful girls. I got to be their doggy mom for a while until they went on to the other side, and I feel very fortunate to have had that opportunity. Next, please. I have gone on and fallen in love again. That's Daisy. She's a whippet. I don't know if you guys are noticing this at home, but I like dogs that look like aliens for some reason. Next slide, please. And most importantly of all, of course, is the fact that I get to still be a sister and a daughter and a friend, and all of us in this world know that at the end of the day, this is what we care about, the people in our lives, how much they mean to us, and whether or not they know how much we love them and care for them. Next slide, please. So there is that saying that it takes a village to raise a child. It takes many, many villages to keep a transplant recipient like myself ticking, and I am never without a moment not realizing the gratitude and the magnitude of what it has taken for all of my doctors, nurses, hospital staff, family, donors, donor families, to make it possible for me to be here and breathe one more breath. So let me just take this opportunity to thank all of you out there who are providers, because what you do is an intense and difficult job, and without you, people like me wouldn't be able to be here. So thank you all for that. Next. Now I'm going to turn it over to Dr. Frush.
Thank you, Tiffany. And I think it's probably very clear to all of you who hear Tiffany speak that she is a gift to us as healthcare providers. And so we at Duke are very fortunate to have Tiffany working with us as a member of our team. You know, I think that when we think about how patients can be involved and engaged, we think a lot about that as it regards patient safety. So I want you to think with me for a minute about what's happened in patient safety over the last decade. In November of 1999, the Institute of Medicine released their report, To Err is Human. And it's interesting, if you go back and look at that, patient safety, as we talked about it then, was defined as this sort of effort to prevent unintended harm to patients. We talked about accidental injury and kind of hope that we could prevent that. But what's happened in the past 10 years as what we refer to the patient safety movement is that we've learned a lot, we've gained a lot of insight, and we now recognize that patient safety is a science, a discipline that really uses a systems approach to improving healthcare processes and outcomes. We recognize today that healthcare is so complex that it really has evolved beyond the capability of any single provider. Patient safety requires this shift from how we were trained as healthcare providers as being an individual expert, a focus on our individual performance, to being expert, high-performing teams. And that's why TeamSTEPPS is so critically important to us in the work that we do in patient safety at Duke. It's interesting that Lucian Leap and other patient safety experts have also commented that included in this shift from individual experts to expert teams is the inclusion of patients and families in all aspects of care. Next slide, please. So what is the role of patients in patient safety? It's interesting when we look back at some of the work that we've been doing over the past decade, we really have to admit that most patient safety strategies are focused on error prevention, on mitigating harm from our perspective, the perspective of healthcare providers, healthcare systems. And, you know, to a large degree, we've left out the perspective of patients and families. Now, some organizations, like the World Health Organization, have began to think about this early on, and they've highlighted the role that patients and families can play in improving safety. I think it's really critical that we understand that role better and that we think about and understand the barriers to engaging patients in our efforts to improve safety if we really want to make more progress in reducing adverse events. Next slide. So that's what we've been trying to do at Duke. And with the help of Tiffany and many other patient advocates, patient members, and patients and family members, some of whom are on this call, we're really trying to challenge ourselves to think differently about what it means to partner with patients. We're really trying to encourage patients to take an active role to facilitate opportunities to speak up, not just to put signs on the wall to speak up, but to create a safe environment. I'll tell you that we talk a lot about culture when we talk about patient safety. And this culture of truly inviting patients and families into the conversations that we have as healthcare providers is a change in culture itself and sometimes can be pretty humbling. Next slide. Next slide, please.
Sorry, Karen, it's not going forward.
Okay. So I think we can probably just go head on with the discussion. In trying to listen to patients and families as they're helping us with that, we've set up some guiding principles for patient and family-centered care at Duke. These are some of these are goals that we're working toward, but we really believe that patients and families are recognized and welcomed as important members of the healthcare team here, and that we commit to engaging, educating, and empowering patients and families to easily access information, to participate in care, and to be part of the decision-making process. We've made a commitment that the core principles of patient and family-centered care will guide our quality and patient safety improvement efforts in our communications. We are certainly not perfect. We have work to do, but we're on our way. Next slide. An example of sort of actualizing these principles is the creation of our Patient Advocacy Council that was actually established in 2005 by Dr. Victor Zhao, our Chancellor of Health Affairs at the Duke University Health System. This is a sort of a patient forum that was created so that we could ask patients and families to advise us on our communications initially. They advise us on much more than our communication. We bring many initiatives, efforts to this group for advice, for input. And I think we've gotten a lot better about really recognizing that what comes to the Patient Advocacy Council is not just what we as healthcare providers think needs to be there, but it's the priorities that the patient and family members on the council think are the priorities as well. This Patient Advocacy Council is a subcommittee of the highest level Patient Safety Quality Committee in our health system. We call it the Patient Safety Clinical Quality Executive Committee. We have minutes from these meetings and the activities of the Patient Advocacy Council are taken forward to our board of directors, who keeps a close eye on the work of this group. We also include the Patient Advocacy Council in our work with our 5-year plan for patient safety and quality at Duke, our quality agenda. And I think that the work of this group and the meaning of this council is reflected in our core value. We have health system values, and the core value is to provide every patient and family with the best healthcare experience. We've been working on this for a while. Again, people like Tiffany and others on this call are helping us with it. I'm going to turn it back to Tiffany now to talk a little bit about the logistics of the Patient Advocacy Council, and then move on to talk about some specific TeamSTEPPS tools that help us with this work.
Thank you, Karen. So next slide, please. So before I started working at Duke Hospital, I was actually a volunteer here on the Patient Advisory or Patient Advocacy Council. So this is just a brief overview, and I'm sure many of you are familiar with these kinds of councils and how they are structured. But we do a standard screening and interview process, and we have to have approval on several levels before someone can be put onto the council. We have orientation now where our patient family advisors as well as our staff are required to be oriented to what does it look like to partner with patients and families and staff in this particular way. So we actually have a 4 or 8 hour training that we offer, or actually are required here at Duke for the council members. We also have a clear governance or charter. Each of our meetings for the DUHS, the Duke University Health System Council meetings, are 2 hours. There's always a special program. Usually it involves one of our staff or several of our staff members coming in and talking about initiatives that they're having challenges with and getting feedback from the patient and family advisors. And then, of course, there's council business. That structure may be slightly different depending on the different council because we do have more than one council within Duke Health System. We do focus groups. We also have a lot of our own projects that we initiate. We are involved in projects throughout the health system. We participate on committees by sitting in and providing the patient family voice when there's a project redesign or a program redesign, or if there's a billing template they're trying to work through. There's a wide variety of things that we might be helping with. And then important for today's discussion, but important in general, is the fact that we now have roughly 10 of our council members that are trained as TeamSTEPPS Master Trainers, and we actually teach some of the modules at the training that Duke provides, the national training that Duke provides, which in my opinion is a great example of what partnership can look like, allowing patients and families to participate in something that is considered to be strictly clinical or strictly for staff really kind of brings to the surface our commitment to the patient-family partnership with staff. Next, please. So as a TeamSTEPPS Master Trainer, I can tell you that I am a huge, huge fan of TeamSTEPPS. And I would say that there is one more layer to TeamSTEPPS that we have an opportunity to work on, and that is incorporating the patient and family into the team using the tools that are so valuable and easy to use. And so we're going to be talking about 3 of those tools just off the top of the list here, but I can tell you that almost every TeamSTEPPS tool is really something that can be used to engage patients and families. If you'll remember earlier on, I talked about that fine line between being an effective patient advocate and an offensive patient advocate, and I think this is actually an answer to that question because we are now going to be able to provide tools to our patients and families. When we say to them, speak up, we now can say not only we'd like you to participate, but this is how you can participate in the most effective way. We talk a lot about the culture of healthcare and how it is shifting, and that is usually in reference to staff and providers. But what we also have to think about is the culture of patients and families. and where they are. And unfortunately, as a patient advocate at Duke, I can say I know that some patients and families still have a fear of speaking up. They fear that they might offend someone. They even sometimes fear that there might be retribution. So not only do we have to give permission for people to speak up, we have to invite them to speak up and help them to understand how much their voice is needed as a part of their care. And then we give them the tools that we're about to talk about. Next slide, please. So all of you are probably familiar with SBAR. In the clinical arena, SBAR stands for Situation, Background, Assessment, and Recommendation. When I teach SBAR to patients and families, I've changed a few of the letters, as you can see here, and I mostly recommend SBAR be used in an emergency department setting or in a clinical outpatient setting. That doesn't mean, however, it couldn't be incorporated into an inpatient setting. But the purpose of this is to allow patients to walk into those two settings and be able to communicate with the providers in a clear, concise way that will make sure that all of the information is properly exchanged while also streamlining their communication. So I ask folks to write down their symptoms, which might sound a little bit strange, but if you've ever gone into the emergency room, you know that sometimes you get that deer in the headlight syndrome. And when they ask you what it is that brings you in today, you can only remember a part of the list of symptoms that you have. So this allows us to make sure that our patients are communicating everything that is important about what brings them in that day. I ask people to write down their background, relevant background, which might sound a little strange as well. But if you have an extensive history, or even if you think you have an extensive history, sometimes it's hard to know exactly what it is that the doctor or the nurse wants us to talk about. I started my healthcare journey in 1973. I'm pretty sure you don't want me to start in 1973 when you ask me that question. So it's important for me to have some time to think about what it is that is my relevant background that you need to know today. Assessment might also sound a little strange because, of course, I'm not going to assess myself as a patient. I'm there for the doctors and nurses to assess me, but there are two pieces of information that I can provide. One is I have never had these symptoms in my life. This is brand new for me. Or two, I have had these symptoms in the past. This is what it was the last time, and this is how we treated it effectively. So that's a great jumping off place for anybody. And then finally, request. That's similar to symptoms in the respect that you might forget something. So if someone comes in and they do an intake for me in the ER and then they leave, that's typically when I remember that I'm a diabetic and I haven't eaten all day and my blood sugar starts crashing. So if I write down my requests, like I need pain meds or I need a blanket or I need food, then that will help us streamline our communications. So next slide, please. So the next slide, or the next tool rather, is one of my favorite tools for patients and families. I think this one really exemplifies the fine line between effective and offensive in that the tool gives us a way to communicate concerns that is not going to make the person listening to us feel defensive. So CUS is I am concerned, I am uncomfortable. And when it's used in a provider setting, it's usually, this is a safety issue. I don't recommend that patients and families use S for safety, only because I would hate for them to use that word if it was not truly a safety issue and then they've lost their credibility. So I changed the S to scared. So I am concerned, I am uncomfortable, and I'm scared. If you listen to those three statements, is there anything in those three statements that I have said that accuse you of doing something bad or point a finger at you and say you did something wrong? Absolutely not. They're all I statements. And so this allows the patient to communicate what it is that's concerning to them without offending anybody. Next, please. And then finally, patient safety call-out. There was a time when I used to ask patients and families to think up their own phrase to use if they felt like there was a concern or a question that needed to be addressed immediately, especially if it was a safety concern. People would come up with things like, whoa, or I'm confused, or something like that. But what I found when I went to Tacoma, Washington, in Madigan Hospital, was that they had already actually incorporated this into their practice. When a patient was admitted to the labor and delivery floor, they would train them that if they had a question or a concern, they should make the timeout symbol with their hands, like you see at a baseball game or a football game. And what I love about that tool is that, number one, if it's taught to me, I'm going to feel much more comfortable using it. And number two, it's a tool that's not medical mumbo-jumbo. It's something that I've actually used in the past. It's something that I am familiar with and comfortable with, so I'm more likely to use it. I also like it because it's something that I can do even if I literally don't have the voice to speak up. So this is a tool that I'm a big fan of for a patient safety call-out. Next slide, please. So some of you might be thinking this is all very nice, but not all of our patients and families are going to be able to use these tools as you're outlining them. And that is absolutely true. I'm not saying that every patient and family member can start with SBAR or start with CUS. But what I am saying is that it is sort of like a educational process of going to elementary school, high school, and college. So if you're in college, you would be an expert patient and family member, and you might be able to start off with SBAR. You might be able to use CUS right away. And those are folks, in my opinion, that would more likely be chronically ill people that are familiar and comfortable with our healthcare systems and ready and excited to embrace new tools so that they can more effectively communicate. If you're in high school, maybe you're not ready for that yet, but that doesn't mean you can't start working towards that. And one example of that might be that you start tracking your own data, whether that's pulmonary function tests, whether that's BUN and creatinine, but keeping track of what's going on with your own personal data so that if anything changes, you're actually going to be aware of that and can communicate that to your physician. Also, I no longer will allow a patient to say that there's the blue pill and the pink pill because we really need our patients and our families to be conscious of what the medications are, what their names are, what their dosages are, what they might interact with. This is all part of partnership. And then finally, somebody might be in elementary school, which simply means that maybe they're completely overwhelmed and just not emotionally ready for any of the high school or college level tools. Maybe this is the first time they've ever been in a health system environment and they just don't know anything about how things work. And so giving them a one step at a time tool is an option for them to help them kind of understand what partnership looks like. Next slide.
So before we get to questions and answers, just want to talk a little bit about where we are in the work that Tiffany is describing. I think you can hear once again how fortunate we are to have Tiffany and members of our Patient Advocacy Council who are trained as master trainers in TeamSTEPPS to join us in this work. We feel very strongly at our TeamSTEPPS courses. In the past, we always wanted to have the team. We almost all the time have physicians, nurses, educators, and now, to Tiffany's point, most times and almost every time we have a patient who's been trained as a master trainer as well to join us because we believe that we want to model the team that we believe is so important. We have ideas about tools that Tiffany described to you as to the use of TeamSTEPPS tools by patients, but at this point in time, we don't have the data or the evidence to demonstrate the impact of this. So I just wanted to be transparent and clear that what we're sharing with you are some of our ideas, our work in progress, and we hope to be able to more formally evaluate some of the approaches that Tiffany has been speaking about, and certainly we'll share that information with others as we have it. So I just wanted to take a chance before we go to questions and answers to thank all of you for taking your time to join us. I want to thank Chris and his team extended team for the opportunity to serve as a training site for TeamSTEPPS, because, again, we believe that this is a critically important part of our comprehensive patient safety approach at Duke. And mostly I want to thank Tiffany for taking the time and sharing her story and her expertise with us as we continue on this journey together to learn more and more about what it means to partner effectively and to develop a true partnership with patients and their families. So, Chris, we'll turn it back to you for the next section, including questions and answers.
Thank you so much, Dr. Frush, and thank you, Tiffany, for the presentation. That was really great, and I appreciate it. Thank you. We are ready to open up the question-answer period now. We don't have any major questions coming into our texting discussion area, so I'd like to open it up to the operator to see if there's anybody ready to queue up and ask some questions verbally.
Thank you very much. Ladies and gentlemen, at this time, we would like to open the floor for questions. If you would like to ask a question, please press *1 on your touch-tone phone now. Questions will be taken in the order in which they are received. If at any time you would like to remove yourself from the questioning queue, please press *2. Once again, if you would like to ask a question, please press *1 on your touch-tone phone now.
While we're waiting for questions to come in, we did get one in the discussion area that says that is curious whether or not the Duke Health System Board of Directors asks questions about patient safety or TeamSTEPPS.
So we are very fortunate to have a board that's very active in our discussions about patient safety. I mentioned that minutes and information from our patient Advocacy Council go to the board. We have a pretty robust discussion about patient safety and quality metrics and activities with our board's Committee on Safety and Quality that meets 5 times a year. We have actually brought members of the Patient Advocacy Council to those meetings to present to them directly some of the work that's going on. I think the board has a pretty good feel for the importance of active patient engagement in the work that we continue to do. The board challenges us as well, and if they feel that we're not bringing them information that they want to see, they'll send us back with a homework assignment. So I think we're pretty fortunate with the board members that we have here.
Dr. Frush and Tiffany, how do you go about introducing this process to your patients? And do you do it with every patient in the hospital?
No, I'll speak to that. This is Tiffany, simply because I'll be honest with you in saying that most of the training that I've done at this point using TeamSTEPPS tools has been independent. We are looking at ways to bring it more formally into the Duke setting, but at this time it's really more of a grassroots effort, something that I've personally taken on, but not something that has wide implementation at this point.
But I think, and that's, as I was talking about the fact that we don't have the data in a formal evaluation yet, what we do have is a lot of anecdotal information now, and also lessons learned from others who are doing similar things at their institutions, to the extent that as we have recently revamped the orientation for patients and families who are going to join us on both the Health System Advocacy Council and on more local advocacy councils. And by local, I mean unit-based, service line-based, where we really get closer to where patients are and receiving their care. We're teaching about TeamSTEPPS tools as an example as part of this to be able to help provide those patient advisors and advocates that work more closely in the clinical units about tools that they can use in their daily work. So we are on the journey. We will learn more, and as I said, we'll be happy to share that as we learn it.
And I will just add one more small piece to that, and that is that we have created a separate module for the National TeamSTEPPS training called Partnering with Patients, where we do go into these tools and some others in a little bit more detail. So the hope is not only are we influencing the Duke culture, but perhaps we're helping to spark some thought and innovation for those attending the TeamSTEPPS training.
Thanks. Tiffany, when you were talking about the timeout, what you do with patients when you teach them about using the timeout signal, can you describe what the protocol it is that you use to teach that signal?
Well, as I stated, it was actually a Madigan Hospital in Tacoma, Washington that had implemented that. So really, again, it's a similar idea in that we as Duke, I can't say have implemented it in a formal way. It's more of a grassroots effort. But I know that in Tacoma, Washington, my understanding was that it was part of the admissions process. And I could be getting that wrong, so please don't hold me to that. But my understanding was that it was when they came into the hospital and they were going through the, the admitting protocols and the admitting information, that they were informed during that time that this was a useful and needed tool for them if they had any questions or concerns during rounds, especially, but also in other circumstances.
So these patients that, what do you do with patients that might be concerned that there are repercussions of speaking up, of doing any of the things that you teach them, even though it's something you invite them to do?
So this is Karen. It's a great question because it's whether patients have concerns about repercussions just as providers. And let me just talk about that a little bit more. We continue to talk to, for instance, medical students who we really try to introduce to new strategies to create a new culture, and find that they are still, many of them are still reluctant to speak up if they see somebody not washing his or her hands or following a safety rule. So I think the issue, again, for patients and helping them with concerns about repercussions are very similar to providers who still have those same concerns. And what we're trying to do, again, is to provide more opportunities to participate in conversations where we can have a bit of a safe space. That's sort of part of the patient advocacy and advisory type council where, I think there's an awful lot of value of bringing providers into conversations that they might otherwise have, as well as patients and their families, where we're openly talking about these issues and acknowledging that with patients that providers are still reluctant to speak up as well, but that we are providing these tools and trying hard to help leaders and providers understand that the behaviors that they choose in efforts to model an environment of mutual respect are fundamental to our ability to convince patients that it's okay to speak up. And so, as Tiffany mentioned, the training that we do is both for providers and patients, because this environment that provides people the courage to speak up is one that, in healthcare in general, we still don't have yet. So I think there's a lot of work that we're doing on both sides of the partnership, providers and patients.
I'd like to just build onto that a little bit, too, from the direct bedside perspective as a patient advocate working primarily in the area of oncology, but all throughout the hospital. I think that the answer to that question is really a case-by-case basis, but really it's about helping people understand that speaking up doesn't mean necessarily and usually that someone's going to get in trouble, which a lot of people are worried about, nor does it mean that they're going to get mad at the patient, but really it's that we're always trying to look to improve and we're always trying to look to strengthen the relationship between provider and patient. And as a patient advocate, it's important to help some of the providers understand that when you're getting feedback from a patient that might feel negative, that really what we're doing is we're working to understand our opportunities and strengthen our relationships. And so from a patient advocate perspective, I would say that it's really a conversation in the moment with both the provider and with the patient to help them understand what we're really doing by reframing these words that we use like complaining and helping them understand that we're actually strengthening through this process.
And I'll just add to that, I think one of the exciting things that we've seen is to have these conversations with house staff, with new nurses, with house staff, with folks who, aren't encultured in the traditional healthcare culture that many of us have experienced. But when you have these kinds of conversations with residents and help them understand that their response back when a patient asks them if he or she has washed their hands or has done something about, with a double check for an ID or a medication, that the response, both the nonverbals as well as the verbals, speak volumes and absolutely determine whether somebody's going to have the courage to speak up again. So I think that certainly working with providers at all stages of their profession, but we're seeing a lot of opportunity with some of the next generation providers, as we refer to them, who seem to recognize that this makes an awful lot of sense in terms of a person-to-person interaction and not necessarily professional to patient.
And I'm sorry, I'm going to add on to one more piece of the puzzle, and that is to tag on to what Karen just said, is the fact that our patient advisory council members tell their story and talk about patient-family-centered care and patient partnership and patient-family provider communication at every nursing staff orientation. Our pediatric council, patient advisory council, presents to the residents. So we're using, again, that going back to the impact that story has, we're utilizing our patient-family advisors as much as we can to tell their story in a way that will help our providers coming into this setting and saying that, this kind of communication is not only helpful, but it's what we expect.
So obviously, everything here, we're putting, the patient at the center. And there's, of course, a whole part of the patient's life is spent, not in your care. And so in the light of readmissions and thinking about it through that lens, is there anything that you guys are doing to focus on the transitions of care and as well as the patients once they get home and that kind of self-care? And the person asking the question wanted to focus specifically on the individuals that, Tiffany, you put into the category of high school or the elementary ranked patients, those people that aren't maybe chronically ill and have a more in-depth knowledge of the system.
Well, again, there isn't necessarily a formula that we can plug in here, but I think it's really a mindset that we're talking about. And so if we start to help providers understand that even if you're working with someone who doesn't have the highest literacy rate or is completely emotionally overwhelmed or is brand new to the system, that does not mean that they cannot be a partner in their care. So one example that we often use to illustrate this is that a story that we find in TeamSTEPPS that I won't go into the details, but the bottom line is that in this TeamSTEPPS scenario, there was a medical error made because a piece of the lab work came back that was not read or was read but was not communicated to the patient, and the patient ended up dying at home after being discharged because it wasn't Duke, but in the scenario, the providers did not make contact with the patient and have the patient come back in. And my feeling when I read that scenario was, yes, of course, we want to think about what the providers could have done differently, but equally so, we want to think about how we could incorporate that patient into that scenario. And if I'm going home and the providers tell me that there's one critical piece of lab work that has not come back yet, I feel very confident that if you give me a phone number and tell me, call us by 2 o'clock or call us at 2 o'clock if you haven't heard back from us about this lab work, that's one job that the patient can really take on no matter what their level of expertise is within the health system. So it's really a mindset and really trying to think strategically about what it is that we can do to partner for safety and partner for communication that this patient in particular is capable of.
And it's partnering. It certainly isn't shifting responsibility for care to patients and families, and that can be a fine line as well. But I think the tools that have been described, teach-backs, patient portals, callbacks to patients after they've been discharged, et cetera, many of the things that we're doing, I know that others are as well, and how this all fits together, I think is something we're all continuing to learn.
Well, thank you very much. And there are some more questions that have been coming up in the discussion area, and there may be some questions coming in on the phone, but unfortunately we're almost at the top of the hour, and we're about to finish. So I want to direct everybody that didn't have their question asked to hop on over to TeamSTEPPSportal.org, where you can, and once you sign up to become a member of the portal, you have access to a discussion forum. And in there, feel free to ask any questions that we didn't get answered today. And we also have 3 questions that we're going to populate over there that you could see on the screen right now. What is your biggest challenge when trying to engage patients and their families? Do you currently employ any techniques for patients to speak up at your institution? If so, what are they? And what are some lessons learned from educating patients and their families on TeamSTEPPS and their role in patient safety? And so these questions are really for the whole community, and we'll be in there to answer those questions and to keep the discussion going. But we'd really like, these 1-hour webinars are great to get people to think about something, but as with everything, to make some real lasting change, the conversation needs to keep going. So make sure that if you have a chance and you're interested, to hop on over to the portal, TeamSTEPPSportal.org, to answer these questions for your own institution and to ask any questions that you might have from the rest of today. I'd like to thank all of you for being on the call and being with us today. I'd like to thank both Tiffany and Dr. Frush for being here with us today and for sharing all of their stories and insights and knowledge on this topic. And again, everybody, if you have any questions about even how to access the portal or anything, feel free to email us at this address, and we'll talk to you hopefully all next month when we have a webinar, the same second Wednesday of the month at the same time. Next month, our topic will be on TeamSTEPPS and interprofessional education. So we look forward to seeing you all, and thank you for all being here today.
Thank you very much. Ladies and gentlemen, at this time, this conference is now concluded. You may disconnect your phone lines and have a great rest of the week.